Um, those drugs were generally speaking hormonal agents, estrogens and progestins. So this will be a little bit of a recap of that, but really we're going to focus a lot more broadly on the pharmacology of estrogens and progestins as it relates to some of the non-contraceptive indications. So here are the estrogens. They have their steroidal hormones. We've talked about steroidal hormones all year. They have this very familiar four-ring structure, A, C, and D, right? Those are the four rings. And what really the main characteristic of estrogens is that this A ring is aromatized, meaning it has a six-member ring with the three kind of revolving double bonds. And that basically is the key characteristic of estrogens. Basically, everything kind of derives from that structurally. And even then we have even non-steroidal, these are synthetic, made in the lab, compounds that can also activate the estrogen receptor, as you can see here. So the main steroidal ones that are pharmacologically available, thionyl, estradiol, estrone, and mestranol. And amongst the non-steroidal agents are diethylstilbestrol and genistein. Now, progestins, on the other hand, again, also have the familiar four-ring structure, A, B, C, and D. They, though, differ structurally in a number of few details. There's only a single double bond in the A ring for progestins. And they really, really have a very close structural similarity to androgens. In particular, the estranes, this group here, whereby their structure is so close to androgens is that they do have overlapping activity. But kind of just stepping back, the progestins have a number of different chemical classes, starting with pregnenes. That's derived from acetoxy progesterone. The one that we use most frequently are is medroxyprogesterone acetate, which is this one here. So, pregnane. Estranes, again, are closely related to testosterone, so they have androgenic activity, including norethindrone, which is present in a lot of contraceptive drugs. And then there are gonanes and spironolactone derivatives that, again, vary in terms of their androgenic activity. In the case of spironolactone derivatives, of course, will have some mineralocorticoid activity. Talked about that activity, which is kind of the salt-retaining activity of those drugs when we covered in the endocrine unit earlier this year. Drospirenone is a spironolactone derivative that also has that is also used as part of contraceptive combinations. All right, so what do estrogens and progestins do? They're involved in development of secondary sexual characteristics, including the vagina, uterus, and fallopian tubes. In particular, progestins are involved in development and enlargement of the breast tissue. And estrogens are key for the growth spurt, the pubertal growth spurt, because of their effects on bone. And then you've covered extensively in your pathophysiology material, as well as last week, the various processes with these hormones in the menstrual cycle. So they both exert feedback regulation on the pituitary and the hypothalamus for LH and FSH in various parts of the menstrual cycle. If you remember, estrogens inhibit gonadotropin release more generally, except in the mid-cycle where it causes the LH surge. And progestins also enhance LH release. So they both have those activities, which in turn can have contraceptive properties. There are other effects specifically for estrogens on the bone. They increase bone mass, so they basically increase the activity of osteoblasts, which tend to strengthen and increase bone, and also decrease the activity of osteoclasts, which tend to take calcium out of the bone and return it back to the circulation. So those are key effects of estrogen on bone. That is why estrogen drugs have a role in management of osteoporosis in postmenopausal women, and why estrogen can be critical for maintaining bone mass in women with hypogonadism. Cover all of that. Estrogen also is very key for cardiovascular function. As far as lipids are concerned, they can increase serum triglycerides, which is a bad thing, but generally speaking, they have a very good profile on lipids in terms of reducing total cholesterol, increasing your good HDL, and decreasing bad LDL. So the net effect generally is very favorable with estrogens on the lipid profile. Now, on the clotting, we touched on this last week about some of the thromboembolic risks of contraceptives. And really, this is because estrogens work in the liver to actually increase coagulation factors, specifically 2, 7, 9, 10, 20. And then they decrease the anticoagulation factors, protein C, protein S, and antithrombin 3. All of those effects all contribute to an increase in the coagulation risk. Okay. Now, this is specifically going to be an issue, especially when you're taking estrogens by mouth. I'll touch on it a little later, but orally administered estrogens will, of course, go through the GI tract and undergo enterohepatic circulation, meaning goes from the gut into the liver, back to the gut. And that circulation increases that activity of estrogens in the liver. Now, how do you offset that? Well, it happens to be that estrogens you can also give via transdermal patch. You can give it intravaginally. You can give it as a topical cream, like primary cream. All of those delivery methods for estrogens actually do not seem to cause the same effects on coagulation. So it really does seem to be related to the activity of the liver from oral estrogens due to their what's called the enterohepatic circulation. So keep that in mind when we talk about clotting risk. On the progestin side, we know that they suppress menstruation and uterine contractility during pregnancy. They tend to thin the endometrial lining. On the central nervous system, they affect the basal body temperature. They have some CNS depressant effects. And from a metabolism standpoint, it can increase basal insulin levels, enhance fat deposition via lipoprotein lipase activity, and actually progestins tend to increase LDL. One of the uses of progestins is for appetite and with cachexia, and we think that's some of the metabolic effects. The reason why progestins are effective for that. Right, so getting back to drug preparations for estrogen again, obviously oral is widely used for both contraception and for hormone replacement. One of the, really at the time, was a huge blockbuster drug called Premarin. Premarin is a formulation of estrogens that's derived from the urine of pregnant mares or horses. And literally the generic name, the brand name is called pregnant mares, Premarin. So I don't know how they figured this out, but when pregnant horses urinated, I mean, there is a very, very high concentration of estrogens in that urine. And they basically use that as a way to extract estrogens and formulate it into a pharmaceutical formulation that was made for humans to use. So Premarin was very widely used. There was kind of a peak in popularity for postmenopausal hormone replacement, or we kind of got a better sense of what the risk-benefit balance is. We used to basically put everybody on hormone replacement who was postmenopausal, and Premarin was a blockbuster drug because not only, because specifically the formulation process was so kind of unique. You really can't replicate the specific mix of estrogens in horse urine in a lab. So they basically cornered the market on this. And again, for a long time, that was really one of the only games in town. Certainly there are synthetic formulations of estradiol that was used for hormone replacement, but Premarin had a lot of data and they kind of cornered the market for a while. Premarin, again, you have the oral, but also injectable. Premarin can be used, we see it a little bit in the emergency room for intractable vaginal bleeding. And then topical as a vaginal cream, again, as a way to bypass the liver circulation. Estradiol is the other main pharmaceutical formulation for estrogen. That is available in a number of different forms, oral, vaginal. There is a transdermal patch that's used for birth control, primarily with dot, and various other routes. There are also esterified estrogens, estradiol, valerate, and sulfonate. If you recall, we talked about this for Anaclid, the long-acting depot for hormone replacement in men. These are basically the analogous products from estrogens. Basically, when it's esterified, you give it as a depot injection class. So all of those are available. Their estrogen is very lipophilic, so it's absorbed well. You get a lot of bioavailability when you apply it to the skin, to the vaginal membrane and the GI tract, and it distributes to the intended sex hormone target organs.
Women who are childbearing age, whose ovarian failure can be like age 13. They get that one. How do you think that?
The dosing is different. I get to that a little bit in terms of how you deal with, say, an ovulatory women versus contraception or whatever. There's kind of different levels as far as dosing. And related to that are the SERMs and anti-estrogens. We discussed these in the context of cancer treatment last semester and fertility treatment last week. The SERM, selective estrogen receptor modulators, they basically are compounds that will have different effects on estrogen receptors depending on the part of the body the receptors are located. For example, raloxifene has pretty much full estrogen activity in the bone, which is what you would want for osteoporosis, but it actually serves as an anti-estrogen in breast tissue so that it does not be estrogen-dependent breast cancers. Now, your pure estrogen antagonists, such as clomiphene, will block the inhibitory action of estrogen on FSH, and that, of course, we use to stimulate ovulation. Women who need that. we very briefly last semester discussed fulvestrant, which is a anti-estrogen use of breast cancer. So those are your estrogen formulations and anti-estrogen formulations. Again, for the progestins, handful of different compounds, mostly oral, but of course the Depo-Provera is the key injectable progestin. That again, like the depot estrogens and depot androgens, so long-acting formulation that will give you persistent drug levels. If you remember about Depo-Provera last week, there was an IM formulation and a sub-Q. They both give you, around 12 weeks of contraceptive activity, and the difference between the two, obviously, on the route of administration. Sub-Q formulation is designed for self-administration, or can be given as a self-administered product, whereas the Depo-Provera IM is typically given. Progesterone, norepinephrine, and spironone are some of the other agents, with the latter two, norepinephrine and spironone, being products that are formulated as pops or mini pills, progestin only pills for contraception. And again, just to remind you, those are require strict compliance for optimal effect as an agent, as a contraceptive. So these are the clinical uses for estrogens and progestins. Again, we discussed contraception in detail last week. I won't rehash that too much. Some of the other conditions, though, involve the use of estrogens and or progestins with different regimens. And really what I want you to take away from this is how the regimens may differ, how some of the, say, duration of therapy, doses, that sort of thing. We're not going, like always, not necessarily hold you responsible for specific dosing, but for example, in the setting of normal uterine bleeding, there are certain ways to approach estrogen treatment versus obviously long-term hormone replacement. So we will touch on each of these indications in turn, starting with primary hypogonadism. This is a condition where, or this is basically a term for a number of conditions where basically there is insufficient development or surgical removal of the ovaries. Turner syndrome, for example, is a genetic syndrome where people who are phenotypically female carry only a single X chromosome. This is compatible with life. I treat patients with Turner syndrome in my practice with developmental disabilities. They have very characteristic physical features, shorter in stature. They have some intellectual disability, behavioral issues, but they also tend to be very prone to some of the health consequences, the osteoporosis, those sorts of things that come with low estrogen levels, as well as they don't have the ability to reproduce. So those conditions will require estrogen treatment, but it's not continuous. You basically start at around age 10 to 12 with a low dose of daily estrogen. And then you start a progestin on a cyclical basis after about 3 to 6 months for 12 days of each cycle to help optimize breast development and to avoid endometrial hyperplasia. So they still have the uterus present, but may not have ovarian function. So the estrogen replacement is done with that sort of approach. Last week, you talked as well about the use of contraceptions for treatment of acne, which is a legitimate use, and you can kind of touch on why it works. Basically, sebum production that's responsible for acne seems to be, at least to some degree, enhanced by androgenic effects. Part of one of the telltale signs of someone who's using androgens for like bodybuilding is the presence of acne. So it seems to be a testosterone or at least an androgen-driven effect. And estrogens can actually help oppose some of those effects in the sedaceous. So that's how we think it works. The regimen for acne is going to pretty much mimic how you use, cyclical oral contraception. So there are 3 products that are specifically approved for treatment of acne, including low estrin, FE, which is a combination of triphase and ethynyl estradiol and ephedrone, orthotricycline, or the generic version trisprintek, has estradiol and progestinate in the tricyclic regimen, and then Yaz, which is a low dose estrogen with spirin. Those are all widely used oral contraceptives, but they're also indicated for acne in women. And it's usually if, they basically want the dual benefit of both contraception and acne treatment. Our next indication, dysmenorrhea. That's defined as a lower abdominal pain, cramping occurring during menses. Dysmenorrhea is divided into primary dysmenorrhea and secondary dysmenorrhea. Secondary dysmenorrhea basically involves some other associated condition like uterine fibroids or endometriosis, whereas primary dysmenorrhea basically is the absence of menses. So here we're relying on the progestin component in oral contraception that can suppress ovulation in the endometrium. The endometrium lining basically produces arachidonic acid. Think back to what we discussed NSAIDs. Arachidonic acid is the precursor for prostaglandins. Prostaglandins are involved, specifically certain prostaglandins are involved in uterine contractions, which is actually part of the reason why misoprostol works for abortions, that it basically is involved in contracting the uterus. So in any event, the prostaglandins, prostaglandin precursors are going to be lower in concentration once you thin out the endometrium. So that's why progestins can actually help for dysmenorrhea. How we approach this is pretty much like with typical oral contraceptive regimens like the 21/7 dosing, where you have active pills for 21 days and 7 days of placebo, or you can extend out the active dose for 24 days with a 4-day placebo. So that is the approach to dysmenorrhea. You can go progestin only, but the bleeding gets even regular. So progestin and estrogen combination. Along those lines, estrogens are also used for abnormal uterine bleeding, which basically this is just the bleeding, not necessarily the other dysmenorrhea symptoms. Here we're talking about abnormal uterine pathology such as fibroids or endometrial polyps, or you can see non-uterine causes such as ovulatory dysfunction, kind of like disorders of hemostasis, hemophilia, that sort of thing. So for abnormal uterine bleeding, again, oral contraceptives or the levonorgestrel intrauterine device are helpful. I mentioned earlier, like IV Premarin, other sorts of injectable forms of estrogens actually have been used emergently for acute abnormal uterine bleeding for patients who may come to the ER, for example. Or you can go the non-hormonal route using drugs for bleeding such as tranexamic acid and tranexamic acid, if you recall, opposes the action of blood-busting drugs like TPA alteplase. So that helps for bleeding. And tranexamic acid is often given in 5 days out of the menstrual cycle during the bleeding. Really effective. Right. Next, anorexia cachexia. I talked about this earlier. Basically, this is kind of like a failure to thrive, weight loss, wasting, physical wasting that can be seen in advanced illness such as cancer, AIDS, end-of-life conditions. Obviously, when they're already ill, but now this low body weight can also be a further complication that can worsen their health outcomes. So what we want to do in these individuals, to the extent possible, help stimulate appetite, promote weight gain, and what we will sometimes give, not always, but progesterone, which is an oral progestin, given at really a super physiologic dose, 400 to 800 milligrams a day, is a whopping high dose of progestin. But with that, you can see some modest benefits in terms of weight gain and appetite improvement. It does carry some risk though of edema, thromboembolism, adrenal insufficiency, and hypoglycemia. So, you absolutely weigh the risk and benefits. Usually the other approach is appetite stimulating agents such as dronabinol and this derivative. So that's another way to approach epilepsy. Thankfully, complex patients, but progestins have been used for that as well. And of course, gender affirming therapy for transgender women. This is basically, obviously, the hormonal component. Very often, this will a lengthy process to make sure that the individual is assessed for baseline significant gender dysphoria. They have the capacity to consent to treatment, and they're in a stable general medical condition. Basically, there will be a combination of drug therapy, which will kind of block the androgen inputs and the estrogen that will be more feminizing. So the anti-androgen therapy will start. That will be either like something like spironolactone high dose, which blocks androgens, or again, gonadotropin release of hormone agonists like leuprolide. Then the surgical removal of the testes to help basically eliminate a significant amount of androgen production. And then the estrogens, again, for its feminizing effects, plus or minus progestin. We said that the progestins have a role for helping with breast tissue development. So that can be used in some cases gender-affirming therapy is transgender, but not always the case. And finally, really what you generally think of when it comes to estrogen replacement other than contraception is menopause. Menopause, of course, is where women who are of age experience a permanent cessation of their menstrual periods. Typically, when there's a continuous period of 12 months, that's when menopause is defined. And then it comes from just a loss of ovarian follicular activity that comes again in middle-aged women, typically between ages 45 and 60. The drop in estrogen levels acutely, or not acutely, but over that perimenopausal period, causes a number of characteristic symptoms such as vasomotor disturbances, which of course are hot flashes, and often kind of sweating that goes along with it, mood changes, irritability, sleep disturbances, and over time there can be complications such as osteoporosis, again, the loss of estrogens, and its beneficial effects on bone is going to be diminished. Coronary heart disease is a risk, and major neurocognitive dementia tends to increase in the frequency of postmenopausal pregnancy. So the idea here is to hopefully, with hormone replacement, manage the menopausal symptoms and to some degree help mitigate the other longer-term complications of estrogen loss. But before we get into that, there are some ways to manage the vasomotor symptoms without involving hormones. Actually, a very new drug called bezolbetant or Veozah was approved last year. It basically works as selective neurokinin 3 receptor antagonist. This is involved in signaling in the thermoregulatory center of the hypothalamus, which basically helps to offset some of that, some of the problems with hot flashes and sweating and such. It does have some modest risk of LFT elevation, so you're going to need to monitor women on that for as long as they're on it. But generally speaking, it's well tolerated, some GI side effects. So the Veozah is one way where, again, without necessarily replacing estrogen, you can manage the hot flashes. Another approach is the use of SSRIs, in particular paroxetine capsule, has an FDA approval for management of hot flashes and vasomotor symptoms in perimenopausal women. And then a handful of drugs have been used off-label, such as gabapentin, Naloxone, clonidine, and oxybutynin. So those are non-hormonal options. The other route, of course, to take is with hormone replacement therapy. So again, by replacing the estrogens, you can effectively treat vasomotor disturbances in perimenopause, but it also then gives the other benefits of estrogen replacement that you would expect women to benefit from, including reductions in the urogenital atrophy and vaginal dryness, preventing bone loss, and at least in a couple of studies, some signal towards a decreased incidence of colon cancer. So you have those benefits. The formulations that's used include Premarin, the conjugated equine estrogens, as well as estradiol and estrone. But when we're replacing hormones in postmenopausal women, it's going to be much lower doses than contraceptive doses. So basically a low daily dose of an estrogen given continuously. You can use the oral route, But the, other routes will avoid, of course, the enterohepatic circulation, the vaginal creams, you can maybe locally for the, vaginal atrophy, and transdermal, formulations or other, formulations that avoid the GI tract may be helpful as long as you're keeping that dosing in the hormone replacement range and not the contraceptive range. If a woman still has their uterus intact, they have not yet had a hysterectomy, then the estrogen must be given with the progestin because, again, the risk of endometrial hyperplasia cancer increases. So the progestin will help oppose that effect. So one of the key learning objectives from this lecture is to kind of be able to assess the risks and benefits of hormone replacement therapy in postmenopausal women. So there are a couple of domains which I'll talk about, which can give you a sense of where we may see some benefits and perhaps some risks. We'll start with the cancer. Again, if a woman has a uterus, giving unopposed estrogen, that estrogen will lead to an increased risk around endometrial carcinoma. That risk is estimated to be a 5 to 15-fold increase in endometrial carcinoma. So that is a thing. In women with a uterus, you must give progestin. When it comes to breast cancer, you would think that estrogen in postmenopausal women can lead to breast cancer. Not quite that straightforward. If you are given combined estrogen progestin therapy in women with a uterus, you might see a slightly elevated risk of breast cancer. If they had a hysterectomy, okay, completely remove the ovaries, uterus, or baseline estrogen levels is even lower, and then you give a hormone replacement, you may actually see not just a less elevated risk, but even perhaps a decreased risk of breast cancer post-hysterectomy. Again, you're giving estrogen alone if they already have a hysterectomy. So just really, I think the most important takeaway as far as hormone replacement and breast cancer is concerned is keeping the duration of therapy 5 years or less, meaning not a indefinite free-for-all for as long as they're alive, really limiting hormone replacement therapy postmenopausal women to 5 years is where you kind of get at the point where the breast cancer risk remains kind of within acceptable limits. Beyond that, that risk goes too high. What we think is that, oxidative damage from estrogen metabolites and obviously feeding hormone-sensitive breast tumors are contributing. And then I briefly mentioned earlier, it seems to kind of be a small signal, but for what it's worth, there was a WHI study that showed that hormone replacement therapy in postmenopausal women actually has a small protective effect against colon cancer. So that's kind of the takeaway as far as hormone replacement and cancer. As far as cardiovascular risk, we said that generally the story is positive with estrogens. So again, they slightly increase triglycerides, but they have a favorable profile as far as LDL and HDL. When you add progestin, those benefits are not as prominent as progestins actually have a negative effect on lipid profile. You may see more biliary cholesterol leading to gallbladder disease. May actually get some moderating effects on blood pressure. Of course, the bad news is that estrogens will increase the risk of thromboembolic disease. So it will have a higher risk of MI stroke because of formation of blood clots, particularly when taking estrogen unbound. And finally, hormone replacement and osteoporosis. So again, estrogen loss in postmenopausal women can lead to thinning of the bones. And it's not surprising that giving hormone replacement can reduce fractures by about 1/3. Here, the benefits are seen when estrogen is begun soon after menopause, so preventing that steep drop off in estrogen for a prolonged period of time by starting the estrogen in the perimenopausal period. And even if they've already experienced a fracture, you can see some improvements with hormone replacement. But if we are kind of just using it for osteoporosis management, it's really not recommended. We have lots of other drugs, which we'll talking about in a minute, for osteoporosis. And really the idea is that if you're using hormone replacement for bone health, it's probably as part of a more broader approach, looking at some of the other issues, the cardiovascular, perimenopausal, vasomotor symptoms, etc. So we prefer to kind of take advantage of this as more of a side benefit as opposed to a primary reason to start this. Okay. Questions on benefits, risks, and hormone replacement? Okay, so we will move into discussion on osteoporosis. Basically, there is a turnover in terms of calcium, which is really its primary reservoir in the body is the bone. Calcium is stored in the bone in the form of what's called hydroxyapatite, which is a complex of calcium and phosphate that make up the bone matrix, gives the bone its strength and structure. Constant remodeling as calcium kind of is exchanged from the extracellular fluid and bone, takes place through a number of cells called osteoclasts, which are bone absorbing cells, and osteoblasts, which are bone forming cells. Their activities influenced by a number of cytokines, including interleukins, necrosis factor, and a pharmacologically relevant one called rank-ligand. So with calcium, of course, the primary way we maintain bone health is dietary calcium. That is through calcium foods in the diet, like dairy, and supplements like calcium carbonate, what have you. Vitamin D is an important player when it comes to dietary calcium because vitamin D helps stimulate calcium absorption by increasing the protein in the GI tract that binds calcium and facilitates its absorption. So calcium, vitamin D has a kind of sympathetic relationship. Parathyroid hormone is another key endocrine factor here. It works in the kidney to help stimulate renal resorption of calcium. It decreases phosphate resorption. Phosphate tends to bind calcium and makes it in the bloodstream, at least, makes it insoluble. So by having less phosphate and more free calcium, then that can then go back into the bone. PTH also activates vitamin D in the kidney. You may recall we talked about vitamin D and its various forms. The active vitamin D is formed through the effects of parathyroid kidney. And it also increases, PTH also increases bone formation by stimulating osteoclasts. Calcitonin also has a role in terms of inhibiting bone resorption and decreasing calcium levels from the blood and moving it into the bone. So this is a diagram of the relationship between dietary calcium in the intestine that is absorbed with a facilitation of vitamin D into the blood. Parathyroid hormone prevents excessive calcium from going into the urine, but it facilitates more calcium going into the bone. And calcitonin basically blocks the activity of wasting of calcium from the bone back into the system. Bone disorders include osteoporosis, which is the gradual reduction of bone mass that weakens bones and leads to fractures. One of the common causes of osteoporosis, again, is menopause. If you lose that estrogenic effect of bones. But if it's from a parathyroid tumor, that's considered reversible. A reversible form of osteoporosis. Other conditions include Paget's disease of the bone, which is excessive bone turnover, and osteomalacia, which is abnormal mineralization of bone tissues. We assess bone health a number of different ways. One of them is using DEXA scans. Basically, it's an X-ray of the bone that is able to determine bone density. The results of the DEXA scan is basically normalized to the general population, where 0 is kind of average bone density in healthy people. They have plus side 1, 2, 3, and 4, with increasing amounts relate to greater bone density and better bone health. You're in the zone of osteopenia if your T-score is between -1 and -2.5, and then osteoporosis from -2.5 downwards. The history of bone fractures also come into play in terms of determining future risk. Again, some of the risk factors around osteoporosis include environmental issues that can trigger falls, like basically obstructions in the environment, unsteadiness from a neurologic cause, musculoskeletal issues, but then also some of the other behavioral and non-modifiable factors such as advanced age, gender, Asian, ethnicity, just having a low bone mineral density, particularly of the femoral neck, and the hip, and smoking, alcohol abuse, secondary osteoporosis, etc. There are medications that can be indicated as well that can accelerate bone load, including glucocorticoids. Protein pump inhibitors are very important in this regard. One of the things that your body relies on in terms of absorbing calcium is to have an acidic medium in the GI tract. Right? And I think we emphasize this quite a bit in GI last semester. Long-term protein pump inhibitors will, of course, block the production of stomach acid, and that will, over time, impact your ability to absorb calcium in the diet and supplements. So, long-term proton pump inhibitors will be indicated for osteoporosis. Anti-epileptics interfere with vitamin D metabolism, so it's not unusual to see patients in long-term treatment. Tegretol, Atlantin, develop osteoporosis, especially if they are wheelchair bound and they don't have big bones. And there are some other causes like chemotherapy, heparin, that are also implicated. So in adults, recommendation is to make sure that they're getting adequate intake of calcium and vitamin D. If there is a vitamin D deficiency, and I can probably estimate that more than half of people in this room have vitamin D deficiency. inside studying all the time, not getting the sunlight you need, or you might be highly melanated with, don't get the vitamin D sunlight that way as well. So vitamin D deficiency will be an indication, of course, for vitamin D supplementation orally. Weight bearing, muscle strengthening exercises, fall prevention, of course, stopping smoking. We said in the previous slide, smoking is a risk, as well as excessive alcohol intake. Calcium, again, yes, one of your most basic, straightforward interventions. We get calcium from dairy, leafy greens, nuts and legumes. The dietary allowance is from 1,000 to 1,200 milligrams of elemental calcium. It's not tremendously bioavailable, even if you have good vitamin D intake. So you get about a 30% absorption. Calcium is available via calcium carbonate. You will recall calcium carbonate is used as an acid, right? Tums is calcium carbonate. So that will actually kind of have a almost an unwanted effect of reducing stomach acid, but you still get enough calcium absorption from that to make it worthwhile. Calcium citrate does not have an antacid property. And it's a little harder to absorb, but that might be a better option for the elderly of those expressing therapy. Calcium tends to be constipating, and it can interact with drugs that it can bind to, like quinolone antibiotics, cytocyclines. We talked about that earlier. And then vitamin D is the fat-soluble vitamin. It actually has a familiar cholesterol structure with 4 rings. It's obtained from fish, fruit, vegetable, and dairy. And of course, then you get it from sunlight exposure. The supplements typically are in the form of calcium, vitamin D3 and vitamin D2. Cholecalciferol or vitamin D3 is intended really for daily use at around 400 to 1,000. I've seen up to 2,000 units a day for cholecalciferol. Ergocalciferol is more of a kind of a time limited, where you get a mega dose of 50,000 units, but that's usually given either once a week or a limited period of time. Whereas the cholecalciferol, there are other vitamin D analogs like calcitriol, calciferol, but that's usually more for either continued suppression or advances. All right, so really kind of getting beyond calcium and vitamin D are the FDA-approved treatments for osteoporosis. They come in kind of 2 broad categories. Either anabolics, which basically promotes bone development, and we have just one agent, teriparatide, that is considered an anabolic bone, reducing treatment for osteoporosis. Most of our other treatments are called anti-resorptive. They basically actively prevent breakdown of bone. That includes estrogens, duloxetine, calcitonin, the rankle inhibitor, denosumab, and really the one drug that is one class of drug that really has kind of assumed the first line type role are the bisphosphonates. These are diagrams that kind of explain the various parts of bone turnover and hormonal other signaling that takes place and where the drugs fall in, but I will explain as we go through the drugs. So we'll start with bisphosphonates again. Temporary medicine, really one of our first line treatments for osteoporosis. So bisphosphonates are analogs of pyrophosphate, where the phosphate oxygen phosphate structure is replaced with phosphate, carbon phosphate. These are anti-resorptive, so they reduce the activity of osteoclasts. And basically, they fall in one of three generations. The first generation, which really is contingent, we don't use anymore. The second generation agent, which includes a couple of familiar drugs, alendronate, Fosamax, and risentronate, Actonel. And then third generation's agents include evangeline, Beniva. As you go from first to second to third, they become more potent, meaning smaller milligram doses produce stronger effects. And, the newer agents have some other indications, for example, hypocalcemia and management of bone metastasis in cancer patients. Bisphosphonates have a couple of really key things that if you're treating your patients, you need to educate them on. For one, it has a fairly low bioavailability that can be reduced further by administration with calcium iron acids. So you really want to separate bisphosphonates from those agents. So we can maximize to really this very minimal extent what little bioavailability we are able to get for bisphosphonates. Basically, because they have that structure that they have, they distribute extensively to the bone, which is the site of action, and they require fairly healthy kidneys for elimination, so you should avoid them again, for 30. One thing to know about bisphosphonates, especially when you take them by mouth, is that they cause esophageal erosions. So based on just having physical contact of the tablet, the oral dosage form, with the esophagus as it transits down the GI tract, you can get erosion of the esophagus. So how you minimize that is by making sure that the patient remains in an upright position so that gravity can bring the tablet down the esophagus as it's supposed to after you take the dose. So really the patient counseling tip around this is to make sure that you take it first thing in the morning on an empty stomach and remain upright for 30 minutes. Empty stomach because of a limited bioavailability, and upright because of the risk of esophageal infections. Other side effects include GI upset and heartburn. You actually can see some bone effects in terms of increased risk of certain femoral fractures. And then an effect which is fairly rare, but can be problematic, called jaw osteonecrosis. So if there's a patient before oral health or after oral surgery and they're on these drugs, they can develop some bone loss and bone disease in the jaw area. Fortunately, we can get away with not having to dose these drugs every day. Alendronate, risendronate can be given once a week. Evangeline Boniva is a formulation that's designed for once a month dosing, and alendronate can be given as an infusion once every 1 to 2 years. So really the oral dosing with alendronate, risendronate is the ones that we're really concerned about as far as the esophageal erosion counts. Questions on bisphosphonates? That's really the one you're going to see the most frequently. But moving on to some of the other agents for osteoporosis, raloxifene, Vista. Again, this is the selective estrogen receptor modulator. It has estrogenic effects on the bone, anti-estrogen effects on the breast and uterus. So this can be part of a strategy to mitigate risk around postmenopausal osteoporosis, but it does carry some of the thromboembolic effects of estrogens that are taken by mouth. PTH analogs, these are your really anabolic agents, really the only anabolic agents that really work more for osteoblasts to increase bone formation. And can take someone from having really brittle bones to help reverse those effects. This is reserved for T-scores of 3 or less, or patients with T-score of 2.5 or less that have a history of fracture. These agents are available as a subcutaneous injection given once a day, and really should only be used for a maximum of 2 years. Beyond that, its effects really begin to look like bone resorption. So PTH analogs, teriparatide, valaparatide, reserve it for your most brittle patients and for a period of 8 years. Its side effects include hypercalciuria, increased calcium in the urine, dizziness, nausea, and palpitations. Another injectable drug is the denosumab or Prolia. This is a monoclonal antibody directed against IgG2, or it's an IgG2 monoclonal antibody directed against the transmembrane protein called rank ligand, RENKL. This ligand, when it's not being antagonized, augments the formation, function, and survival of osteoclasts and bone resorption. So denosumab will basically oppose that action. Also prevents activation of receptor activated nuclear factor kappa B, which kind of inhibits gene expression required for osteoclast formation. So basically, some of this activity is anti-resorptive, much like the other osteoporosis drugs, but works through as a complement. This is a sub-Q injection that's given every 6 months and may require indefinite therapy because here, if you stop treatment, you get rapid bone loss. Unlike Forteo, this you have to stay on it if you are started on. Over time, it will improve bone mineral density and reduce bone fractures, and it's associated with some side effects, including muscle and joint pain, hypocalcemia, the risk of jaw osteomyelitis, like you saw. Bisphosphonates. Then finally, calcitonin. Calcitonin, in the few slides ago, was one of those important endocrine signals that work in the kidney. Here it is an anti-resorptive agent. Inhibits the activity of osteoclasts. It will give you about 6 months of efficacy. But while they're on it and while it's working, there's a benefit of lowering plasma calcium and kind of bringing back to the bone stores. Calcitonin is available as either a nasal spray, which is branded as miacalcin, or an injectable formulation known as Fortical. Calcitonin pharmaceutically is derived from salmon, the fish. Salmon calcitonin actually is super potent relative to human calcitonin, so that's why we use it. It is indicated for osteoporosis at least 5 years past menopause. It's fairly low efficacy, again, can only work for about 6 months before it kind of moves out. Its side effects include nausea and swelling for carried out. Hypersensitivity reactions. I suppose people who may be allergic to fish or seafood have a cross sensitivity to salmon. All right, I have a couple of cases Start with HX. She's 52 years old, Asian woman, slow build. 62 inches or 45 kilos, and she's perimenopause. Complains of hot flashes, diaphoresis, and sleep disturbance. There's no family history of breast cancer, but has a grandmother that died last year with dementia. Her blood pressure and lipid profile are normal. And basically, given this case, how would you explain the potential risks and benefits of hormone replacement therapy to this woman? So what is her primary problem right now? She has vasomotor symptoms, right? So she has the hot flashes, the diaphoresis, the sleep disturbance. Will hormone replacement therapy help for that? Yeah, absolutely. It will give her benefits in terms of managing those vasomotor symptoms. What I didn't indicate in this case, but we can assume, is that she has an intact uterus. So, what does that tell you about potential risks and benefits for hormone replacement?
Decrease of endometrial, increase of breast cancer.
Okay, so the fact that she has an intact uterus means that we would have to give her progestin for so as not to increase her risk unacceptably of endometrial cancer. However, we will not be able to definitively say that you know, we can mitigate risk of breast cancer. The only way to kind of limit that is to keep her duration of therapy to how long? 5 years or less. And as far as kind of cardiovascular benefits, you know, she has a good lipid profile, her blood pressure is normal. You would expect that estrogens will at least maintain that. However, thromboembolism can be a risk. If she's a non-smoker, you know, that can be okay. It's an acceptable risk, but if you're a smoker, obviously, then that thromboembolism risk goes way up. And then finally, the fact that she has family history of dementia. You might say that the estrogen replacement, hormone replacement might offset that. But again, that's only going to be kind of a limited thing. You're not going to be able to treat her long enough to completely offset any genetic load that might lead her towards dementia as she ages. Any other questions or thoughts on this? Our next case is TC. He's 52-year-old. He's a Black male combat veteran with a history of traumatic brain injury. He takes phenytoin for epilepsy, and routine screening reveals a vitamin D level of 12 and a T-score of -1.5. So, what is his risk factor for having such a low T-score? Anti-epileptic phenytoin tends to interfere with vitamin D, and indeed, he has a low vitamin D level. Also, as a Black male patient, he probably is going to have a baseline vitamin D level that's low, even in the absence of phenytoin because of the darker skin tone. So we have that as an issue. That 1.5 is kind of borderline. So in this case, you may not necessarily be in a rush to start treatment for osteoporosis unless he's already had a fracture. But in this case, you will probably want to aggressively correct the low vitamin D through supplementation, as well as getting the calcium supplements as well. But, if you were clinically inclined, you would give an osteoporosis treatment. What would be his first line option?
Sponsoring.
Bisphosphonate, oral bisphosphonate. Obviously, with the, patient education that we discussed. Taking it out into something you never get me right. Question. Finally, we have a 63-year-old female. She's recovering from vertebral fracture and has a T-score of -5. She is already on calcium and vitamin D and takes chetobrazole, the GERD, torvastatin, for lipids, and baby aspirin, which cardiovascular prophylaxis. So what do we do in this case? In this case.
Yeah.
Right, well, she has osteoporosis. She's had a history of a fracture. And we're kind of in a phase of conservative management now with calcium and vitamin D. I heard someone mention the pantoprazole. The problem with pantoprazole, again, it's one of our 15 particular drugs that will raise the GI pH and affect your ability to absorb the calcium. So, again, this kind of chronic long-term PPI for GERD should always be reevaluated, especially in older patients, especially in those with existing osteoporosis. With that being said, you may decide to take her off the pantoprazole. Then that it becomes complicated. Well, then is she going to be at risk for GI bleeding from the aspirin? Probably not, but you have to weigh that as well. But the more important, more acute thing is to then manage the osteoporosis. Again, with a T-score -2.5 and fracture history, that we are going to go ahead and treat osteoporosis with either bisphosphonate or
Since she also has GERD with the bisphosphonates, like increase risk with their esophageal.
It's an excellent question. Yeah, so reflux disease by itself can kind of worsen some of the, not so much the esophageal erosion. If you're taking it first thing in the morning, you're sitting upright and all that, unless you really have very active reflux disease, then that's not so much the issue, but the just the GI intolerance of the bisphosphonate itself might be worse than it would be otherwise. And in that case, again, you would take the bisphosphonate and then several hours later, I would go with like a tonic or something milder as far as the GI, separating it from the calcium. So sorry, separating it from, well, not, but basically using the calcium and as the antacid, separating it from the glycinate.
Is there any way to get the zoldernic acid in like an outpatient infusion, or do you have to be
Yeah, you
inpatient
can
to get it?
that as a like at an infusion center.
Okay,
you
just like
schedule
once
that.
a year.
It's once a year, so it's not, I mean, it's not terrible. That's another way to kind of avoid that. Now, the thing is, once it's on board, it's on board. So you're not going to be able to reverse those effects. So it's, for long-acting drugs like that, you want to at least establish that they have some tolerance of the shorter acting version of it. Because then, that way you know that they can tolerate it. And they're more likely to have tolerability for the long run. That concludes my last. All right, As far as the last exam, this is a cumulative exam, and really the best advice I can give you is it's like a marathon, not a sprint. Make sure you are, just ready and you read the questions. I'm not saying this to be sarcastic or funny or anything. I think so many of the mistakes that I see on the longer exams are just from kind of not understanding what's being asked. So please, make sure you carefully read through the questions and answer them. I'm not trying to trick you. In fact, the cumulative exams, at least the cumulative material, are going to be more just the bigger picture stuff. We're not going to really go into minutia for the drugs, but definitely as we go through antimicrobials, know the big picture stuff about coverage and indications and main side effects and management of allergies, diabetic drugs, the outcomes when it comes to cardiovascular disease and weight profiles and that sort of thing. Insulins, which insulin you use for what condition and that sort of thing. Really kind of the big picture stuff. As far as the antimicrobials, you remember we used for exam 1, exam 2, a one pager that basically has the antimicrobials grouped by generic name and pharmacologic class. We will, I gotta remind Professor Newman, we will have those for the final. So you'll have that available to you, and make sure for certain questions, you're able to refer to that appropriately and know what's what. So that's kind of the big picture for the final. The cumulative material, at least pharmacology, will be 60%-ish, and the rest will be based on the last 3 lectures, second psychopharmacology lecture, and then contraception, fertility, and today's conference. 15 questions total, pharmacology 54, half of, in that 50, it's 30. Sorry, 60-40. Yeah, 60% is the cumulative. So the first 12 lectures will, again, I don't want to say superficial, but very big picture stuff in the first 12 lectures will be the 60% of the pharmacology, and then the 40% are going to be more focused coverage of the last 3 lectures that was not assessed. All right, you've got this, you can do this, you made it this far.